Okay. Well, thanks. Great. Thank you so much, everybody, for joining. And I'm excited to have such a broad group of interested participants. And 15 to 20 minutes is plenty of time to cover all this. And you guys have, I'm joking, you guys have the best questions, so I'm really excited about those. And it's good to see a familiar face in the audience as well. So I started out actually over 25 years ago at University Hospital's Department of Psychiatry in Cleveland as an MST therapist and have really been fortunate to be able to continue working in this treatment model. Um, and I'm at Case Western Reserve University at the School of Social Work in a center. There's lots of centers within where I work. That kind of entails it. That first slide, I'm not going to go into it. Um, But uh, we we already did introductions. I'm going to skip some of this stuff. And you already asked your questions, but please ask questions as you go along. Pop them in the chat or say them out loud. And I'll try to really be very mindful of your time because I know you have other more important things to do as well on this call. So I don't want to hog all the time. But giving you a general overview, MST is an intensive family-based, community-based treatment program, and it really is tailored towards the adolescent client population and it's very family focused. So we really work very much with caregivers of the youth in our program as to be the primary agents of change. So really being developmentally appropriate, we recognize where adolescent brain development is, and moral reasoning and all of those important developmental issues. Our program is really tailored to take all that into account. And we really individualize treatment from start to finish to make sure that we're really, really culturally responsive and that the family is really driving the treatment. And one of the things that's different from a lot of other, home-based treatment programs is that we have a really specific, very specific treatment process that every case goes through, including weekly clinical consultation, quarterly training for all of our teams, an additional quarterly training for all of our supervisors, and really using the data that we get from families, the feedback from families, and the outcomes that we get on our cases to really drive our training, our clinician development, our supervisor development. Um, but we do work, as I said, with adolescents as our primary target population. However, having said that, I know some of you are in the adult system, and I would say when you really look at the counseling that we do, a lot of times we're really targeting the adult caregiver and addressing their needs so that they are more able to meet their child's needs. So that's a big part of what we do. Um, and there's an example up there, of course, of many different behavior problems that might get a youth referred to us. But generally working with adolescents. And they usually have pretty serious behavior problems. And substance use problems is another very, very common co-occurring issue in our cases. Um, it is also very common for our kids to have other co-occurring mental health issues. And However, there's some youth that wouldn't be appropriate for MST because of the way that our treatment model is designed. It's not appropriate for every child, of course. And so, again, as I stated before, we do a lot of our work to really empower the caregivers for that child to be able to meet their needs for the long run. And so it isn't appropriate for a youth who doesn't have full-term, full-time permanent caregivers to get them through to adulthood because of the way that the treatment model is designed. So those youth we would help identify other programs that would meet their needs if a youth was referred to our program but doesn't meet that criteria. And then there's a list of issues there that if, that may make that youth inappropriate, but we always have our referral sources talk to the supervisor of our program to really help think through whether or not this youth might benefit from our program or if they would be better served in a different program. Depending on the community, depending on the funding sources, generally, and somebody at University Hospitals, Rainbows mentioned Ohio Rise, which has really made this program for youth who are Medicaid eligible um, more within reach across many of our communities because now Ohio Rise, and Aetna is the managed care organization working with all youth across Ohio that have been identified as having, very intensive behavioral health needs. If a youth is in that program, they can obtain MST if that's an appropriate treatment for their behavioral health issues. But generally, in most of our communities where we have MST, um, they're coming in from a lot of different doors into the treatment program. And the only program that I would say is an exception to that is in Cuyahoga County at our juvenile court team. We do have an internal program, an MST program that's been at Cuyahoga County Juvenile Court, which is in Cleveland. And that program's been operating about 30 years. So they have their own team of therapists and they work with youth that are referred for having felony level offenses. MSTs all over the world. There's a lot of, not all over the world, but it's in many countries now. And you can see some of them there, which one of the things I love about that is it's allowed us to have a lot more resources in Spanish now, which is beautiful, because Chile has nationwide implementation. And the state of Ohio is one of the states of many that has some statewide infrastructure to implement MST. And that's my job as a network partner director is to work with communities that identify a need to determine if MST is a good fit for their community or in their, continuum of care for youth who have needs. We were started back in 2000 as a center of excellence. When we started, we were back at Stark County Mental Health Board, and we were started by the Department of Mental Health. And in order to support communities around Ohio in implementing MST. I was part of the first independent replication study of MST, and that took place in Stark County, Ohio. And so we were looking at youth who had come out, who had been referred by juvenile court, and were able to find some really nice outcomes compared to usual community service. You would think in 30 years we would have more MST teams across the state, but we do not. It's an ongoing effort. And somebody asked about what are some of the biggest challenges for um, the MST program, given all the changes. And I would say one of the changes that's happened is that this has been awesome that we have case rates now for MST, but the case rate that Aetna gives providers to implement MST doesn't give a differential rate for implementing an evidence-based program that has higher costs associated with it. So that's really been as a CFO, I'm sure they're looking going, well, why would we do this program? Okay, maybe it has research and more resources and better outcomes, but why financially would we do this program when you could do a cheaper program? I'm just being transparent about that being really a blessing and a bit of a curse that we're dealing with right now with the case rates. It's leading people to do programs that aren't necessarily proven to be effective. And in medicine, we wouldn't do that. That would be a last resort if there's no proven treatment, right? But in mental health, we're still trying to change the way that we do mental health. And as you all know, there's sort of an anti-science, expert environment that makes doing an evidence-based program and having the resources to do one, not the most popular thing to do at this point in time. But with those case rates, we do see some growth of our existing MST providers. For example, we have Buckeye Ranch that's been implementing MST in Columbus for almost 2 decades. Now they're going to expand into doing this in Cincinnati. They've already started expanding. And with the care management entity, they're asking them to go into Claremont County where there's more of a need for this intensive home-based treatment and having an evidence-based practice. So we're seeing that being really a nice thing that's happening across the state. We have a really long way to go in terms of being able to get an evidence-based program to youth with high needs in our state. And then we also have an adaptation in the state of Ohio for MST that's called MST PSB, which is a wonderful evidence-based program for youth who have sex offending behaviors. Just phenomenal outcomes. And I'm not going to go into that. You can look at mstservices.com and find lots of great research, way more than I can even, consider presenting today. But that's a really effective program. And so, only one of our providers implements that. And that's the only adaptation that we have right now in Ohio for MST. But there's lots of them, and there's a slide in here that shows you some of them. And one of the key things that we do in MST is we really expect that our clinicians, our supervisors, our consultants, that we all adhere to treatment principles. And there's a slide in here that has some of those. One of those is we're strength focused. So we won't say a family's resistant. Another principle is accountability to providers. So it's on us to figure out if a family doesn't want to engage in treatment, why is that? How does that make sense? And what can we do to engage them? So, for example, right now, with one of the issues being right SNAP benefits, that's going to impact a huge amount of our families. So, parents are probably freaking out. How am I going to feed my children? All right, my kid's acting up at school. That's not where my focus is. I need to make sure I can feed my children, right? Maslow's hierarchy, we all know that. So that clinician would pick them up, go to the food pantry. Let's go to the food pantry. We're not worried about counseling right now because we need to get the family's basic needs met. Um, I'm going to skip some of this. You guys know good clinical skills, good bedside manner, right? We're going to be really focused on not being the experts on the child, which cracks me up a little bit because we call ourselves MST experts. I hate that term because I'm like, we're not experts in the child. We might be experts in the treatment model, but it sets us up a little bit high on a little high. But we really want to be focused on the family, what their needs are, what their ideas are for how to solve issues. Um, but there's a lot of people who, endorse MST as an effective treatment program, and I'll show you a little bit about some of the outcomes because I know some of you are interested in the outcomes. Um, One of the reasons why there's so many champions for MST is it's a huge cost saving to the system. And right now in Ohio, as part of Ohio Rise and Governor DeWine's initiatives, he's really focused a ton on youth mental health. And we're really hoping that that continues in the next administration because, and I was just looking at a mental health report, and Ohio did really well with youth mental health. I was like, I think this is a lot of the result of what's been happening with Ohio Rise and other initiatives across the state that has really invested in children's mental health in a way I don't ever recall seeing in the last 2.5 decades of my work in the field. So, great cost savings, and at the Center of Excellence right now at Case, we're going to be working on looking at what are the cost savings in Ohio for these services. And it's not going to be specific to MST. It's going to be looking at all of the intensive home-based treatments. But we are also being evaluated on MST separately. So hopefully we'll see some cost savings like other states have been able to demonstrate through, funding through Medicaid and avoiding placements, right? If you can keep kids out of placements, you can have some substantial cost savings. Like right now in Ohio, for a youth to go to the Ohio Department of Youth Services, which is our juvenile prison system, that costs $311,000 a year. You know, that's crazy. So if we can invest in these treatments that are way, 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 way cheaper, we can get some substantial cost savings. And so one of the things about MST that's unique is that a lot of treatments will outsource a lot of the work that they do, but the MST treatment program really does a lot of it in-house, in the home with the therapist, leading the way, doing the case management and the counseling for the family and not doing a lot of outsourcing except for things like pro socials and mentors and that sort of um, intervention, and also of course psychiatric services. Our teams do not have psychiatrists on them themselves, so they would be working with providers in the community to make sure that if a youth has need for medication to address their mental health issues or physical issues, that we are helping make sure that they are getting to the right treatment providers for that. So big returns on investments have been shown throughout evaluations of MST. And we really look at using an ecological model in MST. It's really in line, for me, it works really well as a social worker because that's how I was trained as a social worker. And so what that means is that in MST, it's way less important how the youth feels about their clinician as how the youth feels about their family, about their peers, their community. And so we work really hard in MST to empower caregivers to be able to address the needs of their child for the long run. Now, I'm going to stop real quick. I know we're short on time, but I want to ask what people guess or expect would be the number one predictor of adolescent delinquency and substance use hanging out with. And I could certainly think of times myself, like when was I getting into trouble? When was I doing stuff my parents wouldn't want me to do? It was whoever I was hanging out with. I was very rarely getting into trouble by myself. So that is true so we really look at the research. Research informs what we do in practice. So that's why in MST, we'll work really, really hard to try to avoid kids going into group treatment. And, if they're in group treatment, can we pause it? Can we try this family-centered approach? Um, We'll work really, really hard to steer kids towards more positive peers. And then you had talked about some of these other drivers or contributors to youth substance use and behavior problems. And some of them are on there, and you're all right about those. Those are all important contributors. And what we do in MST is we do a very thorough assessment of the multiple systems in a child's life, and we look at the strengths and the needs. And then we use that information to inform, like for this particular child, where do we start impacting? Where do we start addressing the contributors? Some of these we can't impact, right? Like I can't necessarily impact the fact that a child has low verbal IQ. However, I have seen in one summer of intensive, we got a youth involved with really intensive, um, he did this very intensive like tutoring program. Next time his IQ was evaluated, it was like so much higher. And so, there are some things we can impact, but we can't impact everything. So we're going to choose very carefully which to address first. Um, and then the idea being that if we can improve the family's functioning, we can improve how the youth is interacting with peers, how they're performing in school and in the community. What are they up to in the community? We might get them linked with pro-social activities or with a mentor, with the whole goal of being reduced antisocial behavior and improved functioning. I'm going to skip some of this. We draw from different evidence-based interventions. And so again, it's going to be totally individualized to the individual child and what their assessment shows they need or they could benefit from. So CBT, and again, a lot of times we're doing the CBT with the caregivers so that they can model. For example, maybe our youth, escalates very quickly. Well, no surprise because the parent escalates very quickly, right? So instead of working intensively individually with the child, we're going to work with the caregiver to address their reactivity if we can. If we can't, then we're going to look who are the other resources in that youth village that loves them, cares about them, and maybe can coach them if we can't get the parent to a place where they're more able to coach the child. We have very small caseloads. We're available 24 hours a day through our on-call system on the teams. And we typically don't refer out a lot of services, which I think is a huge reason why we have such high engagement. We're coming to the families where they're at in the home. I'm not going to talk a lot about CQI, but there's a lot of it and a lot of feedback. I mean, I love the data. I love that every family tells me how every therapist is doing every month during treatment. And those scores are correlated. Those scores have been shown the higher the adherence, the lower the criminal recidivism, the lower the placement. So we really focus on training and supervisors is it even higher impact on the child's recidivism. So we work really, really hard to train our supervisors to be able to support their clinicians. Um, there's a whole bunch of slides here, but I know I'm up on 20 minutes, so I'm going to stop and just talk a little bit about some things I didn't talk about before, and you all can look at the slides and email me anything more that you want to talk about or set up a time to meet and talk with me. But Brian asked a good question about how do we incorporate the family, and I think, Brian's done functional family therapy, and he was a supervisor in a functional family therapy program, which is another wonderful evidence-based program, which draws a lot from structural strategic family therapy, just like MST does with the family therapy component. I think one of the differences in MST It's really common in MST to be doing a lot of work, maybe separately with the caregivers to get them ready to do family work. So it's a little bit less of the traditional family therapy. I always say it's like family therapy plus. It might mean that I'm meeting with grandma and grandpa and Uncle Rick to talk about like, okay, well, the kid's running over to your house. Like, how can we help you guys to collaborate with mom? Yes, she kicks him out of the house, but like, can we work together so that we don't have that repeated pattern? So we might be doing work with different systems. And then also we might quickly in MST, because we have low caseloads, we might quickly be able to get into the schools. So if a youth is at risk of getting expelled from school, suspended from school, if the MST therapist, if the family, the caregiver isn't ready yet to start intervening in other systems, then the MST therapist will go and try to get started with the school staff and we'll meet with the school staff and we'll get their input on what's going on with the youth and be transparent about what we can impact presently. You know, we want to get the parents to be running all the interventions with their social support network, but that is not always where usually we need to work with them to get them there. So we just want them to know like there's some support. We're working on these things, but this is a 3 to 5 month program. So we wouldn't expect that everything would be addressed immediately. There's a lot of outcomes and data that I put in the slides that Nicole, you're going to share with everybody afterwards, right? So people can look at that. MSTservices.com has a really, it's tons of research there. And then there's some also that's on my, on our pages website at Case. Um, there's also something that has different jobs in MST. So that's another one. If you're looking for a change, take a look and see what there is. But I'm going to stop and ask for questions now, general questions.